Hello, everyone. Welcome to, I believe, the fourth. No, it's the fifth live review. Hey, how's it going, Emma? How was the Oskies yesterday? No pictures of anything. So most of it's going to be just descriptions of things that I described on histology, vacuoles, the spongiotic dermatitis. You'll see I mentioned it looked like a sponge or something, so it'll be descriptive. All the nodules, lesions, all those things. Make sure you know all those descriptors of all the different lesions we talked about in the very, very beginning of derm as well. The reason why I do it with no pictures is because you really need to learn how to describe a lot of these lesions, especially in derm, on the chart. Whenever you guys are writing your notes, you always want to have it in your mind that you are not going to be the person to see this patient next. So you want to be as descriptive as possible so that if you don't see the person next, whoever comes in behind you and sees them knows exactly how the lesion looked at the time of your note. So just getting in a good habit of doing all that. Yeah, even split, palm and derm. Okay, so for the violent throwing up, that's petechiae, just from the increased pressure from vomiting, and the act of vomiting causes petechial lesions. It's the splinter hemorrhages in all the vessels in the face or whatever. Telangiectasias are the spider veins. They're red. So we have a person's nose. That is telangiectasias. Mainly seen on the nose. Sometimes you'll see it on the cheeks. Some people get it on the belly, and if they do have it on the belly, it's a sign of a bigger thing that you guys will learn about over time. Okay, afferent and efferent parts of the pulmonary nervous system. Let me just delete all this stuff. Okay. So when you're looking at this, think about these into the lung. What input is going into the lung? What's going to happen with that lung? So parasympathetic. Again, not even looking at what's on the paper. Always go back to fight or flight, rest and digest. If I'm in that parasympathetic mode, I'm not trying to run around anywhere. I'm relaxed and calm, and you don't have to do anything. Your bronchioles have a tone to them, so they're in a constricted state. We'll put it that way, but in a relaxed state as well. They're not wide open, and they're not totally tight where they're causing an obstruction either. But they have tone. Now, if the parasympathetic system is stimulated, mucus gland secretion, okay, get stuff out of your lungs, promotes mucus secretions. Think about also mucus secretions in the GI system, which we're going to learn about. Rest and digest. Sympathetic system, fight or flight. So we know fight or flight, we have to get air moving in our lungs. We need big airways. So bronchodilation with the sympathetic system. Smooth muscle relaxation, pulmonary vasoconstriction. We're going to open up the vessels into the pulmonary vasculature, promoting more blood flow, more perfusion through the lungs, therefore more oxygenation of the blood through the lung system. Smooth muscle relaxation allows that bronchus to open up wide, get great airflow, great ventilation. Remember, we're talking about airflow is just ventilation, the movement of air in and out. Ventilation, that's all it is. These other systems, they exist as well. ATP, nitric oxide. They're non-adrenergic, non-cholinergic, which means they're not parasympathetic and they're not sympathetic. They kind of fall into their own category. So they call them NANC, and they also have an effect with regards to inhibitory events, including bronchodilation. So again, helping with airflow, ventilation, bronchodilation. The afferent side of things. This is what the lungs are receiving from stimulation, and it's sending the signal to the brain of what's going to happen. Bronchopulmonary stress receptors. So as we start exercising, we start running, we're going to start breathing more. As we start breathing more, our lungs are going to become ventilated more. As they become ventilated, it's just kind of sending the signal to the brain saying, hey, we are doing some exercise, we're increasing our ventilation, we might want to start increasing our heart rate and starting the sympathetic response because, hey, we're doing something, our ventilation is going up, let's increase our heart rate, bronchodilation, better airflow, more heart rate to, again, oxygenate that blood, get it going. We have irritant receptors, okay? Whenever you swallow something and it goes down the wrong pipe and you start coughing, that's your irritant receptors. It's a protective mechanism to help with trapping pathogens as we breathe it in. Remember, we have to keep, we're exposed to the air. We have to be able to breathe in and out. We need protection. Irritant receptors help with that. Coughing, okay, mucus secretion, bronchoconstriction, okay, coughing. These are the results. Getting that phlegm going to trap those pathogens. The phlegm is basically the mucus. Trapping those pathogens in the mucus, and then we, when we cough it out, and we spit it out. Remember we talked about chronic bronchitis. They lose this ciliated stratified epithelial cells. They can't clear things, so they're always coughing. All this mucus production because they're in this constant irritation going on, constant mucus production. And last are the C fibers or fibers from the juxtacapillary or J receptors. They respond to mechanical and chemical stimuli. Best thing to think about this one, hot wings. Breathe in that capsaicin. It's or if you're eating it, it activates your J receptors. What does it do? Shallow breathing pattern. Have you ever had really, really, really hot wings before? You start breathing that way. If you start watching hot ones and they start, what they're doing is the chemical stimuli of the capsaicin that you're inhaling as you're eating them irritates these receptors. So Gabby, I hope that answers your question with regards to the efferent, afferent pulmonary nervous system. Thank you, Holden. So, Chelsea, the reason with emphysema, so remember with emphysema, they lose, first of all, with emphysema, let's do it this way. Emphysema is a disorder of the tissue of the lungs. Chronic bronchitis is a disorder of the airways of the lungs. However, they are both considered obstructive diseases. When it comes to emphysema, it's a disorder of the tissue. They lose the elastic recoil of the alveoli. So remember, normally your alveoli look like a bunch of grapes. Now, all those grapes, they do have some recoil to the alveoli. So as they expand, we breathe in, there is a recoil of those alveoli. Very small, but there's a recoil. And what that recoil allows them to do, squeeze, push the air out, and you breathe out. With emphysema, they lose all that. And what happens is because they lose all the elastic property of their lungs and the alveoli turn into one big alveoli. You lose your surface area, so all your diffusion goes down. Because their diffusion goes down in this regard, they start retaining a lot of CO2. All that CO2 turns them pink. And that's why they're pink. It's from increased CO2. So, because they lose the recoil, it acts like an obstruction disease. So we have airflow is decreased, but expiratory time is lengthened because I have longer time for me to exhale all the air out of my lungs. So as I'm expiratory time goes down. However, are you talking more about FEV, forced expiratory volume, like FEV1, with regards to emphysema? And while you get back to me about that, if I answer your question, Chelsea, then you're all set. If not, let me know. Let me go with Gabby regarding the edemas. Okay. So, and I'm going to redo this slide. I can see how it gets a little confusing with this one. Let me just erase everything from class. Okay. Okay. So, first one, hydrostatic edema. So we're talking about hydrostatic edema. So it has to be increased hydrostatic pressure. That's all it is. If you look at the edges, everything looks nice and clean. Okay? There's no issues at all with regards to the endothelial surface layer, the epithelial surface layer. This is just hydrostatic pressure is increased through the pulmonary vasculature. What are the main reasons for having an increased hydrostatic pressure? Congestive heart failure and your mitral stenosis. So hydrostatic pressure is always going to be, well, congestive heart failure is always going to be a form of hydrostatic edema. So remember, we're talking about pulmonary edema. So hydrostatic edema due to congestive heart failure, mitral stenosis. So remember, with mitral stenosis, you have a fixed stenosis in that mitral valve. So we have a fixed obstruction in the mitral valve. Blood can't get through the mitral valve, so blood's going to fill up the atria and back up into the pulmonary vasculature, increasing hydrostatic pressure, causing pulmonary edema to form. So that's hydrostatic pressure. The next one is epithelial damage. And if you look, it's this layer up there. If you look at how damaged all this looks, this is the epithelial layer. This is due to irritant gases and near drowning. All these irritant gases go out and they cause destruction in the epithelial layer, causing pulmonary edema to occur. So that's epithelial damage. So just know epithelial damage is irritant gases and near drowning. That's all you got to know. The next one is endothelial damage. So this is now the inside layer of the vessel. All those little green cells, you can see how damaged those are now compared to how they looked up here. Nice and long and thin, very, very smooth. Again, hydrostatic edema, there's no damage to any tissue. It's only with the other ones where you get damage with it. So that's all I want you to know for this slide. Know that hydrostatic edema, congestive heart failure, mitral stenosis, epithelial damage, irritant gases, and near drowning, and endothelial damage is your ARDS, acute respiratory distress syndrome, endotoxemia, and fat embolism will cause endothelial damage, resulting in pulmonary edema. So I hope those answered your questions as well. Well, think about it, Chelsea. If I lose the recoil of my lungs as I'm trying to blow out, it's going to happen slower because I have a longer time for those alveoli to start collapsing on themselves. Whereas in normal, healthy lung tissue, as you're breathing in and out, those alveoli are able to squeeze a little bit and keep ventilation going. And when you lose it, they lose elasticity. But we don't really look at time to expire. Think of it more of FEV1 is going to go down because it's not. So remember, let's draw this up. Oh. So here's volumes on this side, and this is flow on that side. Let's change our colors eventually. Okay, breathe in, out. So the blue is the normal one. Okay. Let's change the color to green. Green will be COPD. So COPD, they're fine with the volumes. Their problem is the flow. So what is that going to look like? As they breathe in, it's going to look relatively the same, but as they breathe out, it's blunted, squished down. Don't need to know the goal stages of the COPD. But understand what the bronchodilators do when you give them, like what you're looking for, what are you trying to see. So with the COPD, flow is reduced. In 1 second, if I'm breathing in, let's say, it's for easy for math. If I'm breathing in 4 liters of air, 4 liters of air came into my lungs. How much of that air can I get out in 1 second? And that's what I'm looking for in COPD. And that's what's reduced. FEV1 is reduced because I can't get out that much air. In a normal person, it's 80%. 80% of that air or more should be able to get out. So in this case, let's say 3.5 liters exhaled in 1 second. COPD patients can only get out 2 liters of air, let's say for math's sake. 2 liters of air out of the 4 liters they got in. Now your FEV1 is 50% because it's just like stroke volume and ejection fraction. How much can I get out? And that's also added into this chart just to fill it out. We'll do it in black. The last one is your restrictive diseases. Remember, with restrictive diseases, it's like putting a straitjacket on and trying to breathe. You can't. And what is affected? Volume. So because it's volume, they're going to have a smaller circle, but it's still going to look relatively the same and maybe even actually higher than normal with the restrictive, because with restrictive you have actually an enhanced recoil, so they're able to get the air out faster. So remember, with restrictive, it's a volume issue. With COPD, it's a flow problem. That's COPD. And standardized risk factors for interstitial pulmonary fibrosis, which leads into restrictive diseases very well. Standardized risk factors. Are you about this one, Emma? Okay. Um, so let's erase all this stuff here. Okay. So again, etiology, epidemiology, very important whenever we're discussing and describing, um, especially like in your case studies. They're going to say the age of the patient and so on and so forth. Fifth to seventh decade, when they present male predominant as far as this IPF. Major risk factors: smoking and environment. So that's why it's important to ask about occupation. Um, think of like asbestos. I think it's asbestos and like the whole mesotheliomas, um, the dust that they're in, depending on what kind of environments they work at. Um, so that's why you see scleroderma, sarcoid. These are infiltrative diseases. They're infiltrating the tissue. It's just, and if you infiltrate the tissue and you talk about, um, uh, so anyway, infiltrating the tissue is going to get very stiff. It's not going to work as well. Stiff lung loses compliance. We lose compliance, we lose filling. And that's where the issues come in. Natural history of IPF, unremitting progression. It just keeps going and going and going. Once you kind of diagnose someone with it, 3-year survival rate. It's a very fast disease. Risk factors for accelerated progression. What does that mean? Advanced age. So the older that you are, the worse it can get and the faster it's going to progress. Smoking history. Do you smoke or not? Obviously, if you smoke and you have these type of infiltrative diseases, prognosis is worse, progression is faster. Are you having symptoms, dyspnea? How is your standardized assessment? How's your PFTs when you breathe in and out normally? How's your chest x-ray look? What do you see on the chest x-ray? Any history of any pulmonary hypertension? These are all things that will make the progression go faster. So I hope that answered your question. I'll be right back real fast. Dog was like banging on the door. With the EKG with that? The chest x-ray is important for these ones. but I don't remember anything about EKG. I don't know either. Okay, let's talk about TB. So when it comes to TB, I'm going to go to actually to the N one because uh, this one. Let's look at this picture first, and then we'll go back. Okay, so if someone is exposed to TB, 70 to 90% of the people that are exposed to TB will not have any problems with it. It'll go in their system and go right back out. Why? Because we have an intact immune system in our lungs, meaning we have the ciliated pseudostratified epithelial cells, mucus cells to trap these things and get them out. However, in 10 to 30% of the people, they will have an infection due to the exposure to that TB virus. Now, of the people who were exposed to TB and have an infection now, of all the people who are infected with TB, 90% will never develop tuberculosis and they are not infectious. 10% will develop active TB, 5% within 2 years, and another percentage, 5%, many, many, many years later. Now, if you treat them, it's a cure rate, it's a long-term antibiotics. I don't remember exactly if it's all this 5 anymore, but it used to be the mnemonic was RIPES for treatment for TB, like rifampin, isoniazid. Can't remember what the P is. E is, I can't remember. But anyway, you're going to learn all this in classes later on with pulmonary. Now, let's talk about the people. If you're untreated, 5% will die within 2 years. Now, let's talk about the people who have active TB. What is going on with them? So, early infection, immune system is intact. We're good. Infection generally proceeds without any signs or symptoms. May have a fever. Again, these are the infectious people. Maybe only subclinical, may not advance to active disease. So they can go to that latent. This is where you get those GON complexes. Remember, the bacilli like to hang out and live in the apices of the lungs. If we have a good immune system, it'll isolate it, quarantine that area off. It becomes fibrotic, calcified, and remember, there's all the bacteria is inside that, and it's a GON complex. As far as the percentages, you don't need to know the percentages for that chart with regards to what we went before, like who is infected, who's not. So what this chart now is saying, as we get exposed, bacilli are inhaled, they enter the lung, and they deposit in the alveoli in the apices of the lungs. In a good, intact immune system, macrophages, T lymphocytes contain the bacilli, forming the granulomas, which are later going to be called the GON complexes. If the immune system is weak, this walled off area loses its integrity, breaks open. Now all the alveoli that were, all the bacilli that were trapped inside now are released, spread to the next area of the lungs, replicate, do the same thing, and now we start spreading and start getting bigger areas of tuberculosis. Also, now you can start spreading it to other people because now it's exposed in the alveoli and you can breathe it, cough it, aerosolize it in the droplets, and it goes everywhere. That's what we talked about in class. If you suspect TB, they need to go into an isolated room, potentially and preferably negative pressure, so that everything that's in that room stays in that room. But usually the nursing staff in the triage area will take care of that. And if they suspect something as a triage nurse, that is the whole purpose of triage, is to say who's a critical blah, blah, blah. Severities, they need to go right in the back and they'll put them in an isolation room and mask and all that fun stuff. Tomorrow we're going to start musculoskeletal. So moving through, the last bits are all fast, little lectures here and there. Okay, core pulmonale. Okay. So, core pulmonale. Let me release all this stuff. There we go. Okay. So, core pulmonale is a term that we use to describe any type of ventricular enlargement on the right side secondary to a lung disorder that causes pulmonary artery hypertension. And then going to get right ventricular failure that follows. So it's a disorder of the lung or the vasculature. So either the tissue or the lung. And as you start learning about more and more different things, you'll see the different things that fall under core pulmonale. So again, does not refer to right ventricular enlargement secondary to left ventricular failure, left-sided heart failure, congenital heart disorder, ventricular septal defect, which you'll learn with Dr. Ovalle, what that causes, or an acquired valvular disorder, aortic stenosis, mitral stenosis is the other big one. So those are things. Pulmonary hypertension is under core pulmonale. Pulmonary embolism is a form of cor pulmonale because it's a pulmonary vasculature problem. It's preventing flow of blood through the pulmonary vasculature, increasing pressure in the system, which is going to be reflected onto the right ventricle. Because the right ventricle, remember, that's where the clot came from. Remember your anatomy. In the vein, inferior vena cava, right atrium, right ventricle, pulmonary artery gets lodged there. That increased afterload is directed back into the right ventricle, causing right ventricular stress, cor pulmonale. Not due to anything with the left side of the heart, all on the right side. So I hope that answers your question regarding cor pulmonale, Callie. And Gabby, with regards to plexiform lesions, just know that they're found with pulmonary artery hypertension. That's where you see them. They're formed. So if anything, you're talking about like plexiform lesions or like little berries that form, little aneurysms that form pulmonary artery hypertension. Couldn't take that song anymore. I invited my undergrad students here too, so I don't know if any of them are out there and they want to ask a question, they can feel free to ask a question as well. Okay, so let me do this. Okay, let's talk about, uh, well, Gabby, cardiogenic means it's a heart source. So congestive heart failure is a cause of, cardiogenic cause of pulmonary edema. Um, Non-cardiogenic causes of pulmonary edema, that's that slide we went over before. The endothelial damage and the epithelial damage, whether it's inhaled gases, near drowning, ARDS, those are the non-cardiogenic causes of pulmonary edema that we went through before. Pulmonary edema and pulmonary effusion. So, if we have our lungs, okay? And we also have a very thin layer. Remember the pleural sac that goes around. And we have all of our alveoli inside the lung. I know my drawing is horrible, but I hope you get it. So the black little things on the inside are the alveoli, and the outside of the green, we have our pleural space. Pulmonary edema is fluid in the alveoli. Pulmonary edema, hydrostatic pressure, fluid goes into the lungs, into the alveoli, or the non-cardiogenic causes, the epithelial damage or the endothelial damage, they cause pulmonary edema, fluid in the alveoli. A pleural effusion is fluid buildup in this area, in the pleural space. Now, because we are with gravity and we're upright, this fluid collects. And what happens, if you look at it, fluid builds up, and all this is fluid. That's pleural effusion. Remember, the pleural goes across the lungs as well. So that's a pleural effusion. Whereas pulmonary edema is fluid inside the alveoli. Pleural effusion is in the pleural space. Callie, I hope that answers your question better. And that's why with pleural effusions, we have loss of that space. We get a haziness. Because gravity, fluid goes down, it makes a line. That's all. VQ in bronchitis. Where's my picture here? Here we are. VQ, we really, let's see if we have, it's big in asthma. Okay. Increased area of low VQ ratios with bronchitis. Okay. So low VQ ratios. Where's my other picture? Okay. So remember, when we talk about low VQ ratios, it's ventilation over perfusion. Look at that alveoli. It's shriveled up, meaning we are having problems with ventilation. So it goes down. Alveoli are perfused, but they're not ventilated. Okay. The number going down, ventilation problem. We're not ventilating properly. Trached in the wrong spot. Asthma causes low VQ because we are having areas of the lung that are not being ventilated. Because of the severe bronchodilation that's going on, parts of the lung don't get ventilated because of the obstruction and the bronchoconstriction that's going on. So VQ goes down. Now, let's look at the opposite now. With a high VQ, go to infinity. We have great ventilation in the alveoli. Alveoli is nice and popped out. It's open, so we have ventilation. What don't we have? We don't have perfusion. Dead space ventilation. Alveoli are ventilated but not perfused. So let's extrapolate this to the lung zones. When we are at rest and we're sitting up, you guys are in class and you're paying attention, the top apices of your lung are not being perfused because they're still being, but they are still being ventilated. There's no blood flow. That's all going to be in the base because of gravity. Blood's going to fall down there. No blood flow up here. So we're going to have very, very, very high VQs in the apices at rest. Dead space ventilation. We have ventilation, we have airflow going on, but there's no blood there to receive the oxygen. So the air is wasted essentially because there's no oxygen, there's no blood there. The oxygen in the lung is useless if it can't get into the blood. And if you don't have blood to an area, we call it dead space because it's not doing anything. We're ventilating, but we're not perfusing. An example, cardiac arrest. Another example, which we talked about just a few minutes ago. Pulmonary embolism. What's an embolism going to do? Embolism is going to cause a clot. It'll get lodged. No blood flow is going to get to that area of the lungs. VQ goes crazy. That's why we monitor it. Because it's going to show us that we have areas of the lung that's not being perfused because we have a P, blocking perfusion or cardiac arrest. Their heart is not pumping. There's no blood going to the lungs because the heart's not doing anything. So you're going to have ventilation, but no perfusion. That's why we keep compressions. Keep that blood moving so you can perfuse whatever's in the lungs. Keep that blood flow oxygenated. It's still going to get oxygenated. Keep pumping that heart. Keep it going. And that's going to help with keeping the oxygen moving throughout the heart and the body and the lungs and everything. So it keeps the blood flow moving. Okay. Hopefully that answers your question regarding VQ. Normally, in the gold standard for looking for a pulmonary embolism is a CT scan with contrast. That's the biggest thing you're going to do, but it involves contrast, so some people can't do it, so we do the VQ scan. And we label the blood, put it back in, blood goes in the heart, goes in the lungs, because it's perfusing it, and it glows under a camera. If parts of the lungs don't glow, then we know that there is a high probability of a clot. But if renal disease, then you gotta do a VQ scan. If any of you are really good with Macs or Apple products, let me know and come see me because I'm borrowing a MacBook because it's easier to sync up than my Surface was. But I don't know a couple of things about it. I've never used MacBooks. So make sure again, remember the descriptions for all of these. Okay, macule less than 1 centimeter, non-palpable. A patch greater than 1 centimeter. Same thing again. Papule, solid lesion, superficial, less than 1 centimeter. Papule, think of acne. Okay, so look at inflammatory diseases for derm. There's your telangiectasias. There's your petechiae. Again, the broken capillary from the severe vomiting is what did that. Purpura ecchymosis is just the really, really big one. And the difference is just the size. And again, they don't blanch with pressure. When you push on them, nothing's going to happen. Okay. So really, this is like the biggest thing to really study. Know that perivascular dermatitis, hives, inflammatory process, no epidermal involvement, just hives, comes out, goes away. There's nothing major with that. Your spongiotic dermatitis, intracellular edema, fill it up with fluid, weeping. That's why those allergic contact dermatitis, those are weeping. If you ever had that, what happens? They like ooze all that serous fluid, straw-colored stuff all the time. Why? Because it's intracellular epidermal edema. There's fluid there. It's going to be weeping. It's going to be oozing out everywhere. Allergic contact dermatitis. Okay, allergic to a reaction. Your skin erupts from an allergic response. Spongiotic, weeping, oozing diseases. Psoriasiform already has the word in it, psoriasis, so we know that it's psoriasis. Elongated ridges, that's a big thing. And then we'll go through that in a second. Interface dermatitis. It's the interface between the dermis and the epidermis. That's why it's called interface dermatitis. What happens? We get a reaction and we get vacuoles that form, the lichen planus, purple lesions, or violaceous. You may also hear it be called purple violaceous. We'll get to that in a second. Vesiculobullous. It's got bulla in the word. Bullous pemphigoid. Splitting of the tissues. Basically, it's like a blister. Dermis, epidermis split. Fluid has to fill up that space in between. As the more fluid goes into that area, the bigger that blister gets. The last one is vasculitis, damage to the cutaneous vessel walls. It'll be very evident about a vasculitis. There'll be other things going on in that one. Folliculitis is an inflammation of the follicle. Acne folliculitis, so this is just your normal acne. Nodular dermatitis, nodules, cutaneous sarcoid. Remember, these are the ones that have the granulomas in the nasal areas. They have nodular formation going on. Okay. In the dermis, that's why they're very thick. They're under the epidermis, in that dermal layer, they get very thick. Remember also in nodular dermatitis, that with it, they're going to breathe in that stuff constantly, and it's going to go into the lungs. Cutaneous sarcoidosis. Paniculitis, just remember it just involves a subcutaneous fat. Erythema nodosum, those black, red, bruised type lesions. on the lower extremity. That's erythema nodosum. It's also can be found in sarcoid as well. But in the nodular dermatitis, we're talking about cutaneous forms of sarcoidosis. And again, here's just another way of looking at the different inflammatory processes that we discussed. Your paniculitis, again, it's the subcutaneous layer that's having the issues. Nodular dermatitis, in the dermal layers where you're going to have the problems. Folliculitis has to do with the hair follicle. Again, plugging of the follicle leads to the acne and the ingrown hairs and all that fun stuff. Your vasculitis, you're going to get infiltrates going in there. Bullous dermatitis, here's your splitting of the two layers of your epidermis and your dermis, and that's going to be filled with fluid. Interface dermatitis is going to deal with the interface between the dermis and the epidermis. That's where we have the problems there. Spongiotic dermatitis, just it's going to be spongy due to a reaction going on, and you have your infiltrates here coming up. Psoriasiform, we talk about reet ridges, and that's what these are, these reet ridges. Very, very sharp edges there. And your perivascular dermatitis without any epidermal change. Again, epidermis is fine. Everything is in the dermis layer. Okay, so here's your psoriasis, your psoriasiform. Remember, silvery lesions. Epidermal hyperplasia, very well demarcated. Silvery appearance to these plaques. And they all fall off. Look how these scales. And also, remember, with psoriasis, there are some other clinical manifestations of psoriasis. In the nail beds is one of them. Extensor surfaces, flexural surfaces also causes psoriatic arthritis as well. So it's one of the other ones that has this seronegative spondyloarthropathy. It's arthritis, just due to psoriasis. Interface dermatitis is your lichen planus, causing issues here. In the dermis layer, again, remember that, causing vacuoles to form, known as vacuolization, vacuolopathy, liquefaction. And again, it's liquefaction because it's the necrosing of the tissue. And when the tissue necrosed, it leaves a open space, and that's the vacuole. So again, lichen planus, your drugs is the one that really to look out for with regards to lichen planus. Therapeutic gold. Here's your antimalarial agents. We talked about quinine in that case study for the review we did last week. And then the example from class, someone mentioned they had a family member on anticonvulsants. So again, lichen planus, Wickham striae, those little white little lines everywhere, violaceous in color, so it's that purple color. Very weird. If you were to feel it, remember, it gives you that type of sensation as you were to put your finger over it. It will give you that type of sensation. Also get different severe forms. So erythema multiforme, make sure you understand causes of erythema multiforme, HSV infection, meds or idiopathic. Remember also these dusky lesions. The inside become dusky because of the necrosis that occurs. These lesions start in the middle, and then remember they spread out. And as they spread out, causes the inside to necrose, looking lighter in appearance than the rest of it because it's dead tissue. Give you those target-like lesions. Make sure you also remember the erythema multiforme major ones, Steven Johnson, and toxic epidermal necrolysis, TEN. Make sure you understand the differences between the two. And there you go as well. Remember the mucosal involvement. So remember when you're studying these things, know is it just a skin issue, or does it involve the mucosal layer as well? So the mouth, anus, and so forth. And eyes is mucosa as well. Your bullous. Remember, there's pemphigoid, bullous pemphigoid, and pemphigus. Pemphigus is the actual real disease. Very poor prognosis. But if it's bullous pemphigoid, it resembles clinically the bullous pemphigus. Better prognosis with the oid version. And remember, it's a splitting of the two layers, and fluid fills the area, causing the blisters to form. And then right here is the splitting of the layers, and fluid is just filling that area. And here's these very, very tight blisters. Again, the layers are split. Fluid fills the area. They become very tense because they're filled with a lot of fluid. Skin can't stretch as much anymore, and sometimes they pop. And you can see this is a popped one right there. Here's a popped one. There's a popped one because the skin is very pink. That's the new skin that's being grown underneath it. Whenever you scratch yourself or you got a big scrape and it gets very itchy, remember the itchiness is granulation. That's new tissue forming to repair that damage. It gets itchy, but remember to tell your patients don't scratch it, leave it alone because when you scratch it, bacteria is in your nails and you're scratching a wound and you're removing all the structure and the collagen and all the proteins that are there to repair all that. You're ripping it off and have to start all over again. So that's why just leave the wounds alone, let them heal, and they'll be fine. Leukocytoclastic vasculitis, they're going to have palpable purpura. Very, very important. And why? Because they're having vessels that are popping. So what you're seeing, this is blood collecting in the skin. Usually seen in very severe sepsis. But again, a palpable purpura. Post-streptococcal, post-staphylococcal, side effect from different drugs as well. Spongiotic dermatitis, your contact dermatitis, and here you go. Again, these are very wet-looking wounds. They're weeping, yellowish crust. They break down because it's spongiotic. It's losing all the fluid. The skin was keeping it intact. Now we have this allergic dermatitis, and it's a weeping wound because of the edema. And again, spongiosis, all the fluid in the area. Remember, it's a type 4 reaction. Takes a couple of days. Langerhans cells are here, and they help with all that stuff. Remember, it's delayed 24 to 48 hours. And again, changes, allergic dermatitis, changes in soaps, nickel allergies, and so on and so forth. Again, very, very wet looking wound, weeping. These are the ones, if you put gauze on it, they just get soaked from all the weeping that's going on. Paniculitis, again, erythema nodosum. This brownish, reddish, looking bruising And the reason it looks like bruising, remember, these are very deep. This is in the subcutaneous layer. So they would look demarcated if you were to peel back the skin and left the subcutaneous layer there. But we have skin on top. It's got to go through layers, and the demarcation, they worn away, mainly on the anterior lower extremities. And again, deep wounds here. These are your etiologies. This is your inflammatory bowel disease. Okay, not to be confused with irritable bowel syndrome. They are two different things. But inflammatory bowel disease, this includes Crohn's and your ulcerative colitis. Those are your two forms of inflammatory bowel disease. Irritable bowel syndrome, it could be obviously diarrhea or constipation. We'll talk about that when we get to GI. And again, subcutaneous fat layers where you have the problems. Nodular dermatitis, cutaneous sarcoidosis. These are granulomas. Again, if they have them there, they're breathing in those cells and they're going to get into the lung disease, and they present with that perihilar lymphadenopathy. Do I have it written down anywhere? That's what this is. Anyway, I'll write it down here. Perihilar lymphadenopathy. And that's from the lesions that are there. And tuberculosis is a common cause of this. Histoplasma, viruses as well. Again, but these are granulomas. They're in the dermis layer. That's why they're nodular, because they're in the deep layer. So make sure you understand these two, Lofgren's and lupus pernio. Lofgren syndrome has the pulmonary, hilar lymphadenopathy. Here's also that erythema nodosum that we'll have as well. So they're going to have two different types of skin lesions. But the lupus pernio is the nasal rim disease itself. If they have all the stuff in the lungs, then it becomes Lofgren syndrome. If it's just, nasal rim sarcoid going on in the nodulars, then it's lupus pernio. The last one is folliculitis and perifolliculitis. Make sure you know the different terms. What's an open comedome or a blackhead? It's open. If it's closed, it's a whitehead. Cuneiform acnes. Acnes is the bacteria. So again, pathogenesis. First thing, follicular plugging. Skin cells get sticky, and they get stuck inside the pore for the follicle, and it causes follicle plugging. Now all that oil production, because remember this is a follicle, a hair follicle, it's got an oil, a sebaceous gland at the bottom. It's going to keep producing all that sebum. It's going to build up in that pore, and the bacteria like to eat it. So if they have a good food source, they're going to multiply. Eventually that sebum is going to degrade into your lipids and free fatty acids, and that's going to cause expansion of the follicular canal, so the pore is going to get bigger. C. acnes recruits these neutrophils, and now we have contents inside of a vesicle called a pustule. Now we have the raised area with all that neutrophils inside, basically the pus. All these neutrophilic enzymes weaken the wall of the follicle, causing the follicle to rupture. And all those inflammatory reactants that are inside the follicle now are broken and they spread to the surrounding tissues, and they cause irritation and inflammation to the surrounding skin around the follicle, and that gives you the redness around the pore. Now, because we have an inflammatory process, we get lymphocytes, macrophages, and neutrophils come to the area, causing more buildup of stuff, of the pus. We get an inflamed papule, a pustule, or a nodule of acne. Those are the three different things that can be transformed into. The scarring happens with regards to those ruptures. So, again, here we go. Early comedome, accumulation of the epithelial cells and the keratin first. Then we get accumulation of the sebum. All that oil gets trapped, can't leave and coat the hair, it gets stuck inside. All the sebum allows the bacteria to overgrow because they now have a really good food source, and they keep eating overgrown. Neutrophils in the area cause the wall to rupture, and now all these markers of inflammation spread to the surrounding tissue, and they cause a nodular cyst to form, or scarring can occur here if you're really crazy with the digging and the popping and all that stuff. And then different forms of acne. Okay. So I hope that helps, Gabby. Any last minute questions, things to go over? If you want me to do one of these for EKG, let me know. I don't mind doing that either. The biggest thing I can tell you for EKG now is there are plenty of online resources, and the biggest thing is repetition. Like, just keep looking at EKGs, look at rhythm strips, keep looking at them. That's the biggest thing you can do, is just keep looking at rhythms. But yeah, we'll do one as well. And the great thing about using Freeform is that I got the dots, EKG dots already built in. I can make, what's that? 1, 2, 3, 4. Yeah, I got one. Yeah, one big box. And get your little boxes. So yeah, just there's tons of resources. Just rhythm strip generators and just get in the habit of always doing the same order every single time. Always look for the rate, the rhythm. That's all you've really done so far. I think you also done axis and hypertrophy. Those are the big things to get done right now. Rate and rhythm. What's the rhythm? So yeah, I'll do one for EKG too. It's no problem. You're welcome, Callie. Well, if no one has any more questions, we'll end it for tonight. I'll stick around for a few more minutes. I know there's a delay here with the audio and everything, so I'll stick around for a minute. But if I don't hear anything, then I will see you guys tomorrow morning. You too, Gabby. Good night, Jada. Okay, good night, everyone. I will see you guys tomorrow morning.